I'm going to start off by giving you just a couple of minutes background to frame our session. I think many of us here in the room know that there really has been impressive progress that's made towards the HIV epidemic and towards epidemic control in some high-burden countries, but many gaps remain. As we've seen with the IAS surveys, identifying people with undiagnosed HIV infection, the first 90, remains a significant challenge. And identifying especially those who've been recently infected is important for those individuals to gain the benefit of antiretroviral treatment, and it'll be critical to achieving the global elimination of new HIV infections. There is a new rapid test. This new rapid test can be performed in minutes on whole blood. It's a point-of-care test, and can distinguish a recent HIV-1 infection, defined as acquired within the last 12 months, from a long-term infection. And it's based on avidity to particular HIV antibodies, and we're going to hear more about that this morning. And the absence of these high avidity antibodies signifies a recent infection. This test is very exciting because it provides an opportunity to improve the health of people living with HIV and at the same time to advance public health efforts toward epidemic control. So we're going to be talking this morning about tracking with recency assays to control the epidemic. And that phrase makes up the acronym of TRACE, T-R-A-C-E. The TRACE initiative is a program funded PEPFAR, and it consists largely of technical assistance to support the rollout of recency testing and a recency surveillance system in selected countries. And it's part of a comprehensive approach to responding to the HIV epidemic. And it's a collaborative effort by ICAP together with CSF and CDC, ministries of health, and local organizations. Today's TRACE satellite will begin with an overview of recency initiative by Ambassador Birx, and then will be followed by a description of the laboratory validation of the recency test by CDC's Ernest U. Fenway. We'll then hear about some of the initial experiences in the field with recency testing, as well as setting up recency surveillance systems from Ethiopia, Rwanda, Vietnam, and Malawi. In the second half of the session, we'll have a panel discussion that will be moderated by Dr. Andrea Kemp from CDC. And we're going to ask our panelists to consider 3 main topics. And I'm going to ask you in the audience to also think about these topics as well. So I'm going to tell you what the topics are. The first is, what scientific evidence is needed to make HIV recency testing routine with results for individual use? The second is, what should the different use cases for HIV recency results look like? These are use cases for individuals, for surveillance, and for programs. And thirdly, what is the best way to engage communities, people living with HIV, in implementing recency testing? After we have the panel discussion, and we will try to include time for questions from the audience, Dr. Rutherford will wrap up the session at the end. So before we begin, I want to be sure to thank PEPFAR and CDC for supporting this satellite session. So our first speaker is Dr. Deborah Birx, Ambassador Birx, and we're very, very honored to have her kick off our session this morning. Ambassador at Large Deborah Birx is the coordinator of United States government activities to combat HIV/AIDS, U.S. Special Representative for Global Diplomacy. And I promised her I'm not going to read the whole thing. All right.
We've known each other a long time.
So without further ado,
thank you,
Dr. Birx.
Thank you. Thank you. I want you to get to the real country experiences, and I want to just thank Jessica and George and the CDC. And I think you see that sometimes people want to put people in categories of saying you're a treatment person or a prevention person. And I just want to say, having come out of the HIV vaccine field, we lost a decade doing that argument between antibody and cellular responses. Really did. We spent a decade saying, no, it was all antibody. So we did only antibody work, and then we spent another decade doing only cellular. I saying it was only cellular work. I hope everyone understands that the effective vaccines that are going to be come through have both. And so we need both. And what TRACE allows us to do is focus our precious resources in a way that we can have a comprehensive prevention and treatment response at the geographic site where it's needed. So I just wanted to start with that. We think it's part and parcel of public health surveillance and part and parcel of an effective response. If you look now at the UNAIDS report, and I'm sure you've all downloaded it and read it, I think it was very helpful because it clearly shows where we're doing well and countries and communities where we're doing well and countries and communities where we're failing as a global community. And I think recency tests will help us in those communities to really understand and really work with governments to understand policy changes that we need in order to ensure access for everyone. So the TRACE initiative is really about how fast can we go? And as with the introduction, I like this fast, and now. And so we really know that there's a need right now. And as we wait and continue to discuss, not really helping and identify where we need to really focus prevention and treatment resources. You heard what recency is. It's within 12 months. I think that is good enough as a starting point to really understand how these epidemics are evolving, and they continue to evolve. And places where we are struggling are communities and countries and counties where we haven't evolved our prevention and treatment to meet the needs of the new clients. As you identify new clients, you can have that discussion with them about what they need and what the individuals that have as partners will need in order to either be diagnosed or to have the adequate prevention. So this is about a client-centered approach by having as much information as you possibly can to really ensure that they have a complete knowledge of where they are in the epidemic and how important treatment or prevention is. So identifying the infections, critical, using that data in real time. And so it really won't help to have this out there if we don't have the dashboard that goes with it, that analyzes the data in real time, that allows you to move resources quickly. Now, even in the United States government, where we are very heavy in bureaucracy, we're able to move resources within the same fiscal year. This is a big deal because that's what it takes. We don't wait for another planning cycle before we identify how we have to change and target both our preventions, interventions, as well as our treatment interventions, all to interrupt the transmission chain. I think you know currently there are 2 products available. One of them is dipstick, one of them is a cassette. Both of them work. You'll hear the scientific evidence behind that, and both of them have been deployed in a programmatic setting, which is the other critical part to this. But as I mentioned, and thank you, CC, for these fabulous slides, none of this means anything unless there's a dashboard available not only to the governments and to the donors, but to the communities. So these dashboards have to be open, just like the PEPFAR data. Even though ours is hard to manipulate, and I apologize for that. Anybody who goes to PEPFAR.gov and wants to get our data, please download it. I'm not trying to use it on site, but it has to be available to everybody. So no data that we collect anymore is only available to PEPFAR individuals. It's available to the communities because it's the communities that need to understand and have the data. Now, obviously, this all has to be taken into context. So you really need to know the population in your community where you're doing these assays. You need to know what proportion are on ART and early suppressed, because remember, it has to do with avidities to antibodies that we wax and wane dependent on whether you have persistent evidence of virus. So that's really critically important. But I want our focus today to be looking at this as a tool that we're going to utilize to really focus our resources that we all have in a very specific way, have even a greater impact on the epidemic. Now, as always in PEPFAR, it has been now, and we really appreciate the countries and the work that CDC and others, partners of CDC, have been doing. 17 countries now in fiscal year 19, another 10 by the end of fiscal year 20. I tell you, we are in 56 countries. This is 27. That gets halfway. So we're not happy only being halfway. Because I tell you what happened in a whole series of countries. If you look at the UNAIDS report, if you look at Jamaica, 0 impact in incident in the last 8 years. If you look at Central Asia, rising incidents. If you look underneath the hood, every place where we've had key population epidemics, particularly MSM epidemics, we have not made progress. And we have not targeted our resources to the groups truly at risk. Finding really where transmission is occurring is absolutely key. I will tell you, we test a lot. Last year, we tested almost 100 million people. We test a lot. I will tell you the prevalence of testing in our key populations group is less than the prevalence in the population. It tells me that we're not focused in the networks who truly need our services, mostly because of policies or other issues keep away from being visible. So we have work to do in visibility, but the cross really is both what we termed previous concentrated epidemics and generalized epidemics to really allow us to get the insights into where and how the virus is evolving as it moves through communities and populations. Now, right now, people are using this in a parallel methodology as a third test. We don't think that is the long-term solution. We think that these tests can be accurate for HIV diagnosis and also give you the benefit of recency. So we think that these tests, rather than a parallel system, needs to be the second test in the algorithm. And that is where we think we need to go together as a community. Now, you can see what this is combined with self-test. Someone has a self-test positive. He comes in, she's in, gets rapid test number 1, test number 2. Rapid test number 2 is the recency test. Very helpful for that client, but also very helpful to all of us who want to prevent next stage of a new infection. Always viral load. Our viral load is now, across all of PEPFAR, greater than 50% have access. In some countries, it's above 95. We want all countries above 95, and we think the recency test will also drive the access of the client to viral load. We want the client to know their viral result. We don't want the viral result to be something that is maybe in the clinic or maybe a clinician or nurse knows. We want the client to know their viral load result. We think this recency and viral load results will go together. You'll be hearing from the teams that will be coming up next, and that's why I want to stop here to really talk about what has been like to put this into practice, because that's what we do. We take best science that all of you have given us, and it's really a privilege to work in this program because we have huge scientific breakthroughs that have come and that we get to take advantage of both in our prevention and treatment sphere. But our job is then to implement this at scale and to get it covered as close to 95 to 100% because that's what it will take. And so we think it's integral to the public health response, but we also think it's integral to client-centered programs to really be able to have that conversation with clients about why treatment is important for them if they're HIV positive, why suppressing viral load is important for their health, why U equals U, and then to let them know about reinfections. Imagine if you knew a recent infection and would talk about partner notification and notifying your partners, you're only looking at the last year rather than the last 10 years. You see some people shaking their heads in the audience. They have that longer 10-year experience. Imagine having to name all your sexual contacts and people that you are concerned about. So this is important to the clients, important to the public health response. I think it will improve quality of care. You can have a clearer dialogue. Thank you to the ministries of health in the communities that have been working with this hand in hand. And really thank you to the entire PEPFAR interagency of CDC, DOD, and USAID have been really critical in making sure these are taken to scale, and also to UCSF, George, and ICAP, Jessica. Thank you for your work on this. I think my reason to be here today and to be in this entire session is to show you that PEPFAR is serious about recency taken to scale now. Thank you.